Sir, this is the coronal fat suppressed T2 weighted MRI sequence
Sorry,
showing both
I'm going
the.
to stop you there. How do you know it's T2?
Sir, I'm able to appreciate some fluid in the joint space, which is hyperintense, sir.
So stir can give you hyperintense fluid there as well. How do you know this is
Sir,
T2 and
so,
not stir?
sir, then it must be stir sequence because the bone marrow signals are also hyperintense, sir.
Well, okay, so point number one, sometimes it can be easy and sometimes can be a bit tricky to actually appreciate the difference between T2 and stir. Okay, T2 fat sat and stir. They can, and I'll probably try and show you a case where they look relatively similar. There are certain differences that you will be able to pick up with experience, but sometimes it's not. And in these kind of situations, I usually advise the trainees to not use the term T2 or stir. I usually advise them to use fluid sensitive fat saturated sequence. That way you don't know which one it is, and if you don't know,
Okay,
that's
sir.
fine, you're still safe. So this is actually a stir, and I'll come to that why this is a stir. But anyway, so this is a stir. Tell me what you see.
Okay, so there are bilateral hyperintense lesions, altered areas of signal intensity involving the metadiaphysis of the entire tibia on the right side and as well as on the left side. There is also some signal intensity area noted in the adjacent muscles on the lateral aspect of the right leg. The lesions, the signals are reaching up to the cortex of the proximal tibia on the right side and also distally yes and also distally, so there is mild fluid seen in the joint cavities on both sides. On the left side the lesions are well demarcated, more towards the rounded side, and there are also few lesions in the distal left tibia as well. So and the muscles are also revealing hyperintense signals on both sides. The distal femora, although reveals normal signals, and there is no cortical brain.
Okay, how about this one? Does that help you?
Yes, so
How about
so
I put these two side by side? What does that show?
so the lesions which were hyperintense on the star sequence are now appearing hypointense in the previously mentioned areas, and the muscles are on the right side are slightly bulky as compared to the left side.
Okay. Do
The
you think
joint
that's
cavity.
okay? So, just for those who are sitting their exams, and even for those who are not sitting their exams or who are going to be sit on FCPS and things like that, as an examiner, right? As a trainee, your gut instinct is to just go for it. Okay, you just go on and you just go like, yeah, I'm going to talk and talk and talk. As an examiner, right? If I'm sitting there and I'm examining like 100 trainees or even 50 trainees or even 30 trainees, and I do this course regularly, so I'm examining 4 trainees, but it does get a bit tiring. So what you need to do is you need to basically pace yourself in how you're speaking. Okay, that's very important. You need to come across as not just knowledgeable but somebody who's thoughtful. Okay, so you sent you let's just review this case now. Okay, and I'll identify some of the things that you said the muscle is bulky. Well, the muscle is not bulky here. Okay, the muscle is actually abnormal, and that's because if you were to look at this case, right, and I'll window it a little bit. Can you appreciate the window change now?
Yes.
So that is the muscle. Okay, this area here is not muscle. This area here is not muscle at all. Okay, so what is this?
So this must be the extra osseous soft tissue component of
Correct.
the
So this
signal
is extra
intensity.
osseous soft tissue component. Okay, so you need to be a little bit careful. I don't think that anybody will mark you down, but just that when you're in an exam situation, I always advise the trainees that they need to be at the best game possible. So when you say if you see something here, you're very well within your rights to say, I see that there is abnormal marrow signal within the metadiaphysis. There are multiple areas of abnormal marrow signal as well. There is an intermediate signal intensity in the right proximal calf, which may involve the muscle. But I would like an axial plane through that for further evaluation. And that's a very reasonable response, because if I showed you the axial plane, which I'm showing you here, what is all this? This is the
Certainly.
extraosseous soft tissue disease. Okay, so this is the extraosseous soft tissue disease. Now, for those who are sitting the exams, and I don't really want to make this as an exam session, and I want to make this as the teaching session, the differentials that are coming into your head.
Sir, first of all, I'm thinking of any lymphomatous deposits which
Okay,
are involving on both sides of the legs, or it can be a mets,
okay,
or it can be even infective etiology, but infective won't be involving both sides at the same time. So it
okay,
is either metastasis or it can be lymphoma.
very good. Okay, if I was to ask you one of those two, which one would it be?
Uh, Sir, it must be most likely some metastatic
No,
disease
actually, in
process.
this case, it would be more likely lymphoma, and I'll explain why. Okay, so a couple of things right off the bat regarding protocoling, and I have a few sarcoma cases, and I will show you what we do in UK, and I'll explain the rationale behind it. And I think it's very important that I highlight why it is important for you guys to understand that. So, when it comes to bone lesions or bone tumors, we don't really we do T2 in one plane, but most of the time, when assessment of the marrow is best done with T1 and stir. Okay, now you can substitute T1 and stirs with PD and PD fat sat in some cases, and that's absolutely reasonable as well. But the problem with PD fat sats in particular is the fat saturation is not is the fat suppression is spectral, which means that it may not be ideal, and we see a lot of cases. So we have actually resorted at this point in time in our hospital, at least, to stick with T1s and stirs. So when you see a bone lesion, a bone pathology, it's very likely to be T1 and stirs rather than T2 fat sat and things like that. T2 fat sat can be used as well. It serves the same purpose, but we use T1s and stirs. You have to decide based on your own uh, protocol and your own set of skills and your own radiographer team as to which one works best for you. Okay, so this is obviously, you're absolutely correct in terms of your approach and differential. This is multiple lesions, and these are also abnormal lesions. These are not normal, these are all abnormal, because these are not only just low on T1, the corresponding hyperintense signal is bright on T2. So this is multifocal disease, but this large extraosseous soft tissue component is what makes it tilt towards lymphoma rather than metastatic deposits. Metastatic deposits can present with extraosseous soft tissue disease, but I've been doing, we work in a large oncology center and soft tissue tumor center, and etc., etc. We don't see metastatic disease with a large soft tissue component unless the patient has got fracture, or there's hematoma there. When we see something like this, we are always concerned about metastatic, lymphoproliferative disorder, but metastatic disease remains a differential. So, as a radiologist, what would be your first thing to do? What would you do as a radiologist first? Surgeon is standing there and he's asking, like, now what?
So we can stage the disease process by offering an ultrasound abdomen or even a CT abdomen, and just can
Okay.
stage the entire disease involvement.
Yeah.
And also, I would like to refer the patient to multidisciplinary team for further, like if they will decide whether to go for chemotherapy.
Correct. So the first things that, well, you've actually got it good, well done. Yeah, the first thing the first thing you're going to do is basically confirm if you are, like, for example, when we are reporting as radiologists, we don't have the clinician standing with us. We don't have the patient standing with us, so we can't really ask questions. So what we tend to do is we basically look into the history and say, what's the history? If there's a history of lymphoproliferative disorder, we usually then give the appropriate differential. And for us, obviously, it's very important, for the simple reason that we have like we have about 15 different, no, at least 30-35 MDT codes. So if this was a lymphoma patient, this would go to a lymphoma team. If this was known malignancy, we would send it to a known malignancy team, for example, breast or something like that. And if there was no history of malignancy with this large, soft tissue mass and multifocal bone disease, he'd probably go to what we call the carcinoma of unknown primary MDT, where, they discuss the case and identify where to biopsy and what approach to take. So yeah, it's appropriate. It's important to look at the previous history first. Staging is absolutely right. Ultrasound is a waste of time. No, you can't. Okay, tell me what you see on this image.
Sir, this is a grayscale image which show large soft tissue mass lesion involving the regions, sir, is the soft, likely skeletal muscle, and it showed internal Doppler flow in it, show internal vascularity, and it's
Okay.
lobulated and irregular mass lesion.
Okay. What about its echogenicity?
Its echogenicity, it is hypoequic
Hypoechoic as compared to what?
to surrounding muscle.
And
Uh, Sir, muscle and
what's on top there?
uh, sir, tendons,
Subcutaneous fat.
subcutaneous fat. Yes.
Why is that important for me?
Uh, Sir, it's mean it's not of fat density.
Good. Why is that important?
Mm, to discriminate a lesion, whether it is fatty or uh, categorize the lesion in.
Well, the number one reason it's very important is because majority of the lesions, if I was to scan 100 patients with lumps and bumps,
Yes.
I'm pretty sure 90% or even more than 90% of them will turn out to be fatty lumps. Okay.
Okay.
So
Okay.
the purpose of ultrasound is to basically differentiate. You can you tell me what this is on
Sir,
ultrasound scan?
it's sir, likely it is a soft tissue sarcoma, liposarcoma, or
Okay, it is a soft tissue lesion. It could be a sarcoma. We don't really
yeah,
know, but it could be a sarcoma. That's a reasonable guess. But the
yeah,
bottom line is you can't really tell exactly what it is in terms of its nature. What you can
yes,
say is it doesn't look like fat.
yes,
It's irregular. It's got vascularity. What's the
yes.
next thing you're going to do?
Sir, MRI.
MRI scan. Okay, good. Well, I've given you a hint, isn't it? I've put the MRI scan for you. All right. Okay. I've got 4 sequences for you. What I'm
Okay.
going to do is I'm going to try and make the screen a little bit smaller, but put more sequences on. Okay. And this is there's a very important learning point here, and I think from a perspective of for those practicing in Pakistan, this is very, very important. What I'm going to say, it might upset even a few people, but
Okay.
that's not the
Okay.
point. Tell me
Okay.
what you see on this. Okay, you've got 2 sequences. Okay, you've got
Okay.
what is this? This is
Sir,
T1.
T1 lesion, sir. This is there is the corresponding lesion is appearing ISO to muscle, and on
Okay,
the water sensitive sequence, it is appears to be hyper intense.
okay. Uh, so don't be fooled by the name here at the top, by the way. It says T2 TSCX spur. This is actually a stir sequence. Okay, that's the
Yes.
commercial name that's given to the sequence. Okay, so don't look at this and say this is a T2 fat sat. This is actually a stir.
Okay.
Okay,
Okay.
so any comments on this here, on this lesion here?
Sir, as it is not suppressed on the water sensitive sequence, so it's likely a fluid, not of a fat density. It's a fluid or soft tissue density.
Okay, anything? Okay, so if you're a reporting radiologist right now, okay,
Yes.
what are the important things for you to describe on this on like what are the important things you're going to say in your report? That's what I want to hear. I want you to tell me what are the important things you're going to tell the clinician.
Okay. Sir,
First
it's
of all, what do you think it is? Is it aggressive? Is it benign? Question. Is it solid? Is it liquid? That's question number two. Okay. Or actually, let's reverse the question. Question
okay.
number one. Is it solid or liquid?
Sir, it is solid.
Good. Okay. It is solid.
Solid.
How
Yes.
do how do you how did you come about that?
Sir, because I can see lobulation and sort of internal
Good.
septations or
Good. There
something
are
like.
some, well, they're not septations, it's
Yes,
lobulations, it's part of the
lobulations.
mass, okay? They're
Yes.
not really like septations, okay?
Yeah.
But this is not really fluid density, is it? It's not
Yes.
really fluid. It's
Yes.
looking solid. So
Some component
it's,
is solid. Yes.
yeah, it's
Yeah.
solid, okay?
Yes.
Now, obviously, it's a solid lesion, and your ultrasound was there to help you, wasn't it? The ultrasound told you that
Yes.
this is not a fluid lesion; it's a solid lesion.
Yes.
So you've
Solidly
got a
and
solid lesion, okay?
yes.
Where
Sure.
is it? So you need
Uh,
to describe from a report perspective. You need to
yes.
describe where it is.
Uh, Sir, in the sir, can move it a little, sir. I can see the location. In sir, it's in the upper thigh.
It's no, no, no,
No,
no,
no,
no.
so
Okay,
sorry.
so what
Sorry.
vessels are these?
Uh, Sir, it's popliteal.
Nope.
Oh,
Popliteal would be behind the knee. This is in the thigh.
okay.
This is
Okay.
anterior
Sorry,
thigh.
sorry, sorry. Sir, superficial femoral and deep
This is
femoral.
well, these are
Yeah,
superficial femorals,
superficial
okay?
femoral. Yes.
And what's happening to the superficial femoral? Where has it gone now? It's gone into the adductor hiatus, okay?
Yes.
And
Yes.
it's
This
going to
case.
go down, okay? So this
Yes.
is this is almost below the level of the adductor hiatus, okay?
Yes. Yes.
What are you going to tell the clinician? What is the clinician interested in knowing? He doesn't want to just know that there is a lump. That's
Yes.
not his, that's not what he.
Uh,
If I told my surgeon there is just a lump there, go do whatever you want to do with it, he'll turn around and tell me I'm a bad radiologist. Okay, so I need
yes.
to provide
Yes.
certain things to him. What are the
So I
things that
can,
he's interested in knowing?
sir, I can told him to for the localization of the tumor, whether it is indenting or inserting into the some muscles and involving the vessels. Vessel is encasing by
Good.
this ganglion.
Good, good. So you need to tell him where it is. It's in the posterior
Yes.
aspect of the mid to distal calf, okay, just below
Yes.
the level of the adductor hiatus.
Yes.
You need to tell him that there are areas where you do kind of just subtle areas where you can't really appreciate the fat plane,
Yes.
but fat plane inferiorly is preserved, okay. More
Yes.
importantly, there is no encasement of the vessels, and similarly, you have to tell him that there is fat plane which is mostly preserved in the surrounding muscle as well. Okay, I'm not going
Yes.
to quiz you on the anatomy. Okay, that's not the purpose of it. All right,
Yes. Yes.
the
Yes.
sciatic nerve is here.
Yes.
Okay, so sciatic
Yes.
nerve is far away from the lesion. Okay, that's the
Yes.
peroneal, that's the posterior tibial nerve. Okay, so it
Yes.
is above the level of the knee joint, below the
Yes.
level of the just below the level of the adductor hiatus. It's
Yes.
in the. What are you going to do next? Are you going to give contrast? Here are my questions for you. Are you going to give contrast?
Uh, mm, Sir, yes, contrast.
Okay.
Yes.
Okay. Now that you're going to give contrast to the patient. Tell me why you're going to give contrast.
Uh,
What
Sir,
difference would it make? I need to understand that.
sir, if it's a inhomogeneous enhancement, more likely suggestive of a malignant lesion, and it's
Okay.
if it's a homogeneous enhancement, that possibly a benign lesion.
Okay. All right. I don't agree with it. I categorically disagree with it. Okay.
Okay.
Okay. So you basically saying, so number one question that you said was, answer that you gave, the reason for giving contrast was that you're going to give contrast because it's going to help you differentiate between benign and malignant lesions. Okay. That's one. And I'll come to that.
Yeah.
Secondly, second question to you. Would it stop you? What's the next step in management for this patient?
Uh, mm, Sir, mm, further, sir,
What does the patient need?
sir, resection
No.
or okay.
What does the patient need?
Mm,
Before you even touch this lesion or tell the surgeon to take this lesion out, what do you need to tell the surgeon? You need to tell the surgeon what it is. That's not the surgeon's job.
Yes.
That's your job. How are you going to tell him that?
Mm, So
You're going to have to do an ultrasound guided biopsy on this. Okay.
yes, ultrasound guided.
Unfortunately, the concept of sarcoma management in Pakistan is non-existent.
Okay.
It's a dilemma that I unfortunately feel angry and upset about.
Yeah.
But if you see a lesion like this, what this patient needs is a competent radiologist, a competent
Okay.
surgeon, an
Okay.
ultrasound guided biopsy, and
Okay.
a competent histopathologist. And then based on the results of the ultrasound guided biopsy, a competent surgeon should decide to take it out in the most appropriate manner. Okay. How
Okay.
would you approach this? What would be your approach? Would you approach it from the anterior compartment going through the vastus medialis? Would you approach it through the gracilis? Or,
Uh,
sorry, this is sartorius, that's the gracilis. So would you approach it through the sartorius, or would you go through the hamstring compartment? Where would you
mm,
put, where would your needle go? Anterior, medial, lateral, or posterior?
uh, Sir, most likely medial,
Why?
through medial compartment, without any interrupting any vasculature, vessels, and
Well,
mm,
that is one of the concerns, okay? But the
yeah.
most important aspect of where to approach it is not dependent on you,
Okay.
okay? The most
Okay.
important aspect of the approach is dependent upon the surgeon himself. A
Okay.
lot of radiologists don't understand that concept, which is a
Okay.
pity. I may sound, I believe sound like as if I'm very angry. I am kind of angry. I am kind of upset at what happens to patients in Pakistan.
Okay.
Um, but it's a surgeon who decides. Okay.
Okay.
Royal National Orthopedic Hospital, which is the largest tertiary care center in UK, where I did my first fellowship, all the surgeons were there at the meetings, and they would tell the radiologist what track they wanted. And that is very, very important, because if you have a radiologist who doesn't seem to understand the approach, right, and he puts a needle through the hamstring compartment there, and then the surgeon decides to, sorry, can you guys others mute yourself?
Sir, my is muted.
No, no, you
Talk.
are, but
Yeah.
I think somebody else wasn't. So
Okay.
if the surgeon decides that he's going to take this approach, and you decide to biopsy through this approach, what have you done? You basically seeded his hamstring compartment with tumor cells, basically left him with a huge chance of recurrence or residual disease. Okay,
Yes.
so the most important aspect of sarcoma biopsies is the surgeon has to give a clue, or at least tell them where to biopsy them from, because the surgeon will then tell you, okay, I'm going to operate from this aspect, or I'm going to approach it from this aspect. You're absolutely right. If the surgeon doesn't tell you where to go, then you are better off approaching it from the medial aspect, even avoiding the muscle. Okay,
Yes.
because the
Yes.
surgeon may be able to cut up this area. He would want to preserve, if this lesion is not involving the muscle, the surgeon does not want to take out the muscle. Okay, he would want to
Okay.
peel it off. He would want to leave the muscles behind, because muscles play a very important role. The more muscles you take out, bigger the gaps. Okay, bigger the
Okay.
morbidity for the patient. Okay,
Okay.
now this case highlights, so how many sequences did we use
Uh,
for MRI scan?
Sir, T1
How
and
many total?
uh, total, sir. Uh,
4. 1, 2, 3, 4. Okay,
okay.
1
Okay.
stir,
T1,
T1 and
sir.
T2. Now our
Okay.
protocol in our hospital adds an additional T2. We like our additional T2, because on the additional T2, these areas are even more pronounced. Okay,
Okay.
all
Okay.
right, so we like our T2, but we like it with 5 sequences. Okay, okay, this is not a star, so just be careful. All right, this is a T1. Okay, just tell me
T1,
what you see on T1.
in which I can see that is well delineated, well defined abnormal MR signal intensity area along the upper part in the along the upper part of the shoulder, that is hyper intense on T1 sequence, and indenting on the underlying deltoid reaching up to the upper of the shoulder. However, the fat planes between the with the muscles, these are well preserved, and underlying bones and muscles, supraspinatus, all these appears normal to me. And about this lesion, I can see that some some stria, and some uh, hypointense areas. These are also evident within this lesion.
Okay.
Uh,
So you're talking about these.
yes, sir.
So these are called septations. Okay.
Yes, sir.
And we'll
Stria
come to that
septation.
as well. Okay. So what is it that? Okay.
It is
So
T1 hyperintense.
yeah. So what is it?
Sir, first will be lipoma, sir.
Okay. Any other differentials? It's about.
Lipoma or hematoma. I will ask the history of. Uh,
Hematoma. Nope.
no,
This is not a hematoma. What a hematoma looks
sir,
like.
T1 hyperintense, sir.
Okay. Okay. We need to be a little bit careful. Okay. I know what you're saying. I'm not denying that hematoma is a T1 hyperintense. I don't have. I have cases in my library, but I haven't anonymized them, so I can't really show you. But T1 hyperintense of a hematoma does not look anything like this T1 hyperintense. Okay. You
Yes,
have
sir.
to be. You have to be a little bit cautious in your approach in how you say things, and this comes down to how should I put it?
Lipoma versus liposarcoma. Otherwise, if or
Okay.
further, uh, sir,
Yeah.
I will.
Okay. That's fine. That's fine. If you were ever sitting in an exam, right? The rule number one of exams is do not panic. Okay. Just be in charge of your emotions and the way you speak, because that will help you pass the exam very, very quickly. Okay.
Yes, sir.
Now, this is when you say something, you have to justify it, why you said it. And what happens is that the trainees read up a lot and then they don't really bother to explain what they've said. Now, you said T1 is a hyperintense, and I'm not criticizing you. I'm just trying to teach you that basically when you say T1 intense, hyperintense, look at this T1 hyperintensity compared to this one, right? This
Yes,
is
sir.
a lipomatous lesion. Okay, this is
Yes, sir.
what it is. All right. What else is there on that image? On this image, what else is there? She's complaining of pain and swelling. She's complaining of two things which may or may not be related. What other thing is there on that image alone?
Okay. Some sclerosis along the acromion. Some hypointensity along the acromion side.
Okay.
This one,
Okay.
acromioclavicular joint along the
Yeah.
acromion side, sir. I can see
What
this.
is it? Just say what it is, Sarah, if you know
The
what it is.
sclerosis and
It's not sclerosis. You have to be careful. This is not sclerosis. Okay. So
degenerative, as you have said, it is old
she's
lady. Some
74. Yes.
74.
But you have to
Some
be
degenerative.
careful, Seher.
Yes,
You
sir.
need to listen what I'm saying. You
Yes,
have
sir.
to be a little bit careful in what you say, how you say things if you're going to give an exam. Okay. When you say sclerosis is low signal on T1 and T2
Yes,
and
sir.
stirs. Okay. This is more like intermediate signal. Sorry, can others please mute yourselves? So this is not exactly sclerosis. This is more like subchondral reactive changes, because if I showed you a corresponding T2 or a stir signal
Yes, sir.
image, it would appear hyperintense. Then it won't be sclerosis, would it?
Yes, sir. Then it will not be.
Then
Yes,
not
sir.
be. So you just have to be a little bit careful in how you so. So this is subchondral changes. You've got capsular thickening. You've got
Yes, sir.
osteophytosis. This is degenerative change. Okay. You've got a coronal stir there. Anything else that you want to comment on?
Yes, sir. There is fluid signal intensity area along the subacromial region, subdeltoid. That is
Okay.
subacromial bursitis. I can
Good.
say.
Good. What about the tendon here? What
Sir,
tendon
this
is
is the
that?
supraspinatus tendon. Now I can see, sir, when you are scrolling, then I can mention it that there is hyperintensity along the attachment of the supraspinatus muscle along the its groove.
That's anterior. That's the coracoid process. That's the
Yes,
anterior
this
attachment.
is.
Okay.
Then it is.
So what has this patient got? What has this patient got which is causing the symptoms? Patient has got subacromial subdeltoid bursitis.
Bursitis, yes, sir.
What's that ligament going across?
Sir, this is supraspinatus. No,
No, this is a
this
ligament.
is subscapularis, sir.
No, this is a ligament. Subscapularis is here.
This is,
This is the coracoid process.
coracoid.
There's a
Okay, fine,
ligament
sir.
which is going
Sir,
all the
medial
way.
gleno.
No. Medial gleno. You need to look, sir. You're again.
Sir, I can't see any. Sir, see. Sir, okay,
No.
fine, sir. No. No,
that's fine. That's fine. If you can't see, just say I can't really see the ligament.
Sir, I can see the hyperintensity, but I'm unable to define the anatomy as the
If
as
you
scrolling.
okay, all right.
तो सर मैं कर लूं.
No, what you need to do is you need to just, the most important thing is to just keep your emotions in check. Slowly listen to the examiner or the person who's teaching you. This is the coracoid process. There's a ligament which is going from the coracoid process, and when you scroll posteriorly, it goes and attaches to the acromion. What's the ligament? It's going like that. Coracoacromial ligament.
Coracoacromial ligament, sir.
This is the coracoclavicular ligament.
Yes, sir. This is coracoacromial
ligament. And this patient has got a small spur at the inferior aspect of the acromion. Okay. At the insertion of the coracoacromial ligament. She's got degenerative changes.
Impingement.
And she's got impingement, which is causing her to have the symptoms of pain. Now, what obviously they did was they decided to actually give contrast to this patient to assess this lesion.
But it is not showing any enhancement.
Okay, it's not showing any enhancement.
Yes,
if it showed enhancement, would you be able to differentiate between a lipoma and a liposarcoma?
Yes, sir. Of course, then liposarcoma shows heterogeneous enhancement, irregular, defined, infiltrating into the muscles, not well defined. Then I will go
No. You're not listening to what I just said. Contrast does not help you differentiate between liposarcomas and lipomas. I have seen lipomas with variants demonstrating same non-fatty areas, same level of enhancement.
Okay.
Contrast does not help you to differentiate. What will help you differentiate between a lipoma and a liposarcoma?
Size. It's
size can help you differentiate, but size is not the only
irregularity. Predictor. It well marginated or not, and also the symptoms of the patient, its septations. Septations, sir,
no. The only thing that can help you differentiate between ALT and atypical. First of all, you're talking about a liposarcoma. How much fat would you see in a liposarcoma?
Sir, वो heterogeneous signal. It will give heterogeneous signals. Of course, it will not be.
I just told you. Lipoma variants can give you heterogeneous signal. Fat necrosis can give you heterogeneous signal. How would you differentiate between fat necrosis, lipoma variants, and a liposarcoma?
So fat sat images.
No, it won't. It won't.
I can't get it, sir. Sorry.
The only thing that can differentiate is a biopsy.
Sir,